Okay, next case is going to be for Dr. Ria. How are you, Dr. Ria?
Absolutely okay, sir. Thank you. How are you,
Okay,
sir?
Alhamdulillah. Thank you very much. So, okay, Dr. Ria, this is a cardiology case. Okay.
Yes, sir.
Could you please, this is Mr. Stewart, is a 61-year-old gentleman who presented with shortness of breath. Please examine the cardiovascular system. Okay.
Yes, sir.
As you can see now, Dr. Ria, this slide in front of you, just tell me what you want exactly to look for, what you want exactly to listen for, or what you want exactly to observe. Tell me, and I will take you to where the thing that you want to examine. For example, tell me I would like to check for the pulse. I will guide you to where the pulse. I would like to listen for the heart sounds. I will take you to where the heart sounds. Is that clear?
Yes, sir.
Okay, now let me adjust the time. So this is a clinical station. It's 6 minutes station, okay? So
Yes, sir.
examine the cardiovascular system. Now you're as if you are in the exam settings. I want you to go inside. I want you to wash your hands, okay, etc., etc. Okay?
Yes, sir.
Now your time starts now.
Good evening.
Good evening.
My name is Dr. Ria, and I am one of the doctors in the clinic today. Is this Mr. Stewart I'm talking to?
Yes.
Nice to meet you, sir.
Nice to
Sir,
meet you.
I have been asked to examine your heart and your cardiovascular system. Is it okay?
Yes.
Okay. I see here that you are having shortness of breath.
Yes.
First, I would like to inspect the patient and to see if the breathing is regular.
Breathing is regular.
Okay. Then I would go close to him, stand on the right-hand side of the patient, and I would start by a head-to-toe exam. So I would check if there is any pursed lip breathing.
Nothing.
Okay. I would request the patient to pull down one eyelid and see for pallor.
Okay. This is the eye.
Okay. Thank you. Then I would go down and I would ask if I could examine his neck to
Leg.
see if there are any lumps and bumps in the neck.
Neck.
Neck, yes, in the neck.
Okay. This is the neck.
Okay. Okay. Then I would request him to open his mouth so that I can see for any pigmentation, source, or cyanosis
This,
of the tongue. Yes.
this is
Okay.
the mouth.
Thank you. Then I would go down and I would ask him, do you have any pain in your tummy at all?
You're not, no, I don't have any pain.
Okay. Okay. I am going to press on the tummy now and I'm going to ask him to look to his opposite side so that I can check the JDP.
Okay.
Okay.
No
Now, is the
hepatic regular
JDP raised?
reflux.
Okay. Okay. Then I would ask or offer to auscultate his lung sounds first.
Lung sounds.
Yes.
Nothing obvious in the lung sounds.
Okay. No inspiratory crackles or anything?
Nothing.
Okay. Then I would start by by palpation of the heart borders. So first, I would first check um, for any kind of thrill, starting with the left ventricle near the apex. Okay, right ventricle and left ventricular thrill.
Nothing.
Is there anything there?
There is a systolic thrill in the aortic area.
Okay. Then I would go down and check the apex, the location of the apex. Is it in place or is it displaced?
Okay. The
Okay.
apex
Is
is
the
in the
apex?
fifth intercostal space, mid-clavicular line. Heaving in
Okay.
nature.
Okay. Okay. Thank you. Then After that, I would check for any kind of thrill just below the clavicles as well. Is there anything abnormal there?
As I have told you, systolic thrill in the aortic area.
Okay, then I would ask the patient, do you have any pain in your arm?
No,
Okay, I am about to lift your arm and I am checking now for a collapsing pulse by keeping my knuckles over the radial pulse. Is there a collapsing pulse?
no collapsing pulse.
Okay. Um, may I know if the pulse is regular or irregular?
Pulse is 84 beats per minute, regular, small volume, slow rising.
Okay. At this point, I would ask the examiner that I want to take a blood pressure and to check for radiofemoral delay.
Skip it, doctor, no need.
Okay. Then I would start auscultating the heart and I would start with the heart sounds.
Okay.
First, I would
Can you
place
hear
my
it?
stethoscope over,
Okay.
sorry.
Where do you want to put your stethoscope?
Yes, at the apex first with two fingers below the carotid pulse. So first,
Okay.
with the carotid, I am listening to the apical beat.
Can you hear this voice?
Can't hear, sir.
Can you hear this
No,
voice?
sir. No,
Okay.
can't hear.
There is a systolic
Okay,
murmur all over the precordium.
over the precordium. Okay,
Yes.
then I would go up in the fourth intercostal space in the tricuspid area to see if there is any abnormality there.
There is a systolic murmur all over the precordium.
All over the precordium. Okay, thank you. Then I would go down and I would check for, uh, while examining him, okay, I would go down, I would check the abdomen for any kind of distension, any kind of tenderness there.
Nothing in the abdomen.
Okay, then I would go down into the lower limbs. I would check for any bipedal edema.
This is the lower limbs.
Okay, is there any kind of bipedal edema? Doesn't look like, sir.
No.
Okay, then, um, okay, I would ask the patient if he could tell me, is there any history of loss of consciousness?
You are not allowed to ask the patient any kind of history, doctor, in this station.
Okay, yes, I would go near the umbilicus and I would auscultate on both sides of the umbilicus for a renal bruit.
Doctor, this is a cardiac case. This is not an abdominal case.
Okay. So can I also check for the aorta then, at least the aorta in the abdomen, and if there are
No,
any pulsations?
no need.
Okay. Um, um, okay.
Would you like to do anything else?
Um,
Okay, time up. Now.
okay.
Okay, Dr. Ria, could you please present your findings?
I have examined Mr. Stewart, a 61-year-old male patient who has presented with complaints of shortness of breath. On inspection, this patient is absolutely comfortable and is on room air. However, on clinical examination, this patient has a systolic murmur, which is well appreciable all over the precordium and is a systolic murmur in character. The pulse is regular. There are no signs of cardiac overload in this patient, no peripheral stigmata of infective endocarditis.
Have you tested for this,
Um,
Dr. Ria? Have you tested for peripheral stigmata of infective endocarditis?
no, sir.
How could you mention this if you did not test for it? Okay, carry on. What else did you
Um,
find?
um, there was no collapsing pulse, or no evidence of a collapsing pulse on examination. Um,
What about the apex beat?
The apex beat was not displaced. It was
Okay.
well localized in the fifth intercostal space and the midclavicular line.
Okay. What else?
Uh, there was no variation of the pulse with the carotid pulse.
Have you
Um,
checked for the carotid pulse?
for only while auscultating for the areas of the heart, sir.
Have you auscultated the carotid area?
No, sir.
Okay. So,
So
what's your
this
impression?
gentleman is most
So what's your impression?
likely
What is the diagnosis here?
from the examination of the cardiovascular system. My impression here is this gentleman has presented with a
What is your
systolic murmur
diagnosis?
in the, some
Mhm.
probably aortic stenosis.
How could you say that this patient has got an aortic stenosis? Okay, give me the
Uh,
give me the findings that are suggestive for aortic stenosis.
that there is a systolic murmur in the aortic area and is well heard over the entire precordium.
Okay. What else?
Um,
Okay, you mentioned that this patient has got an aortic stenosis. What are the causes of aortic stenosis?
so the causes of aortic stenosis are calcific degeneration of the aortic valve. It
Okay,
can also be secondary to rheumatic fever, although it is quite rare as compared to the mitral valve being affected.
okay,
Uh, it then uh, uh, a bicuspid aortic valve can also lead to an aortic stenosis.
very good. Okay,
Um, okay, then uh,
okay.
um,
What is the triad of the aortic stenosis, Dr. Ria?
the triad of aortic stenosis is dyspnea, syncope,
Okay,
and uh, chest pain.
yes,
Dyspnea,
please.
syncope, and chest pain. Yes.
Okay, so what is the most common symptom among all of these three symptoms?
Dyspnea, sir.
It is chest pain. Okay, what is the most serious one?
The syncope is the
The
most serious
syncope.
one.
Okay, you
Yes.
mentioned that this patient has got a systolic murmur. Is that right?
Yes. Yes.
Okay, what could be the causes? Give me around 3 or 4 causes of systolic murmurs,
So,
apart from aortic
mitral stenosis.
stenosis.
Um, mitral stenosis.
Are you sure mitral stenosis gives you systolic murmur?
Mitral regurgitation will give you a
Okay,
pansystolic murmur.
what else?
Um,
Okay, what about the, how are you going to do? Oh, let me just ask you before the management plan. Give me the features of severe aortic stenosis.
the features of severe aortic stenosis.
Mhm.
Um, so, recurrent attacks of syncope, repeated episodes of left ventricular failure or fluid overload.
I mean, the
Um,
clinical features, the clinical signs of severe
so you
aortic.
will have an ejection. Yes, you'll have an ejection systolic murmur.
No,
So repeated attacks of syncope or loss of consciousness.
these are symptoms. I need clinical findings, clinical signs. A mild aortic stenosis will be having an ejection systolic murmur. Moderate stenosis will be having an ejection systolic murmur. Even severe one will be having an ejection systolic murmur. So the murmur per se, the ejection systolic murmur per se, is not a feature of a severe aortic stenosis. What are the features? Do you know them?
No, sir.
Okay, let me take you now to the management part. Okay, I need you just to tell me how are you going to treat this patient? Treatment.
So first, I would like to elicit how severe is the stenosis by doing an echocardiography. Once
No,
I know the
forget
dimensions
about
of the valve,
investigations. Please, Dr. Ria, concentrate with the question. I ask you concerning the treatment. I did not ask about investigations. Treatment. This patient is presented with, what is the presentation of this patient? Shortness of breath. So this patient, is he symptomatic or not?
he is symptomatic, sir.
Okay,
Yes.
now based on this, now I want you to start, give me the treatment options for this patient.
Okay, so the treatment will be if you start with for pharmacological agents, I would
Okay,
like to start with medications that are going to reduce the afterload of the heart, such as ACE inhibitors and nitrates. They will be very important in offloading the heart. So beta blockers are very important in the management of these patients.
okay.
Okay, and in the severe stages, sir, we will proceed towards an aortic valve repair or an aortic valve replacement.
So
So for
surgery,
those candidates who
you mean? Okay.
are not suitable enough for a surgical procedure, a transcatheter aortic valve implantation can also be opted for.
Okay. Uh-huh. What else?
Um,
Would you like to give this patient any role for a non-pharmacological advice?
Non-pharmacological advice.
Mm-hmm.
Yes, because these patients tend to have syncope, they should not be traveling alone. They should not be doing any kind of strenuous physical
Mm-hmm.
activity.
Mm-hmm.
They should keep the doors of their rooms open and their washrooms also open in case they need any emergency help.
Okay.
They should, um,
Okay. Last question, Dr. Ria. What are the indications of surgery in aortic stenosis?
sorry, sir, I couldn't hear you.
Indications of surgery in aortic stenosis.
An aortic valve area of less than 1 square centimeter. Then a
Mm-hmm.
patient who has severe symptomatic aortic stenosis.
So symptomatic.
Um,
Okay. Uh-huh. If the patient is asymptomatic, you mentioned about.
Asymptomatic. Then, so we will look at the ejection fraction if it is less than 50%. Um, and
Okay. Thank you very much, Dr. Ria. Time up. Okay, Dr. Ria. How do you find the case?
sir, I could have done it better. And I don't know if I'm on the right
I
path.
just want to have some questions, Dr. Ria. Um,
Yes, sir.
the sequence of examination is not correct. I felt that you are jumping from here to here. You have started immediately and then you came lastly to check for the pulse, although the pulse and the nature of the pulse should be checked in the initial phase. And you took a long time, okay, in eliciting some irrelevant things inside the cardiology station. Why do you want to examine for the abdomen in the cardio? Yes, it's very important to examine the abdomen, okay, for any patient with the cardiology. However, in the setting of the exam, you don't need to go extensively in examining the abdomen. Okay, so the steps
Yes,
of
sir.
the examination, you go inside. Okay, you know that you are going to face a cardiology station. You wash your hand, you read the scenario again. Hello, my name is Dr. Ria, one of the doctors here in the heart clinic. Are you Mr. Stewart? Yes. Nice to meet you, Mr. Stewart. Mr. Stewart, can I examine your heart? Full stop. Do not say, okay, I have been asked to examine your heart, and you repeated, I need to examine your cardiovascular system. Cardiovascular system, this is jargon. Keep it simple, Dr. Ria. Can I examine your heart? Okay. And please let me know during my examination if you feel any discomfort so I can stop. Is that clear? Okay, thank you very much.
Yes, sir.
And now you go and check for the anything, if anything surrounding the patient. Okay, and then you need to go and start your examination by the pulse. Okay, you need to start your examination by the pulse and check the radial pulse in the station of the cardio with the minimum of 30 seconds. Minimum of 30 seconds. You need to check the pulse, the rate of the pulse, is it synchronous or not, and the character of the pulse and the volume of the pulse. And then you need to check the pulse on the left side to make sure that there is no any radial delay. Once you have done this, you need to ask the patient, do you have any pain in your shoulder? No? Okay, I'm going to check now for the collapsing pulse. Okay, thank you very much. Keep the head down. Go up and start by examining the eye. Could you please make your eyelid down? And make your eyelid up, checking for jaundice and anemia. And then go down. Could you please open your mouth and tongue up, checking for cyanosis, using the torch. Don't forget this, guys. With the tension, usually you are going to forget. Take the torch nearby and examine for cyanosis inside the mouth. Okay? Now, thank you very much. Now, you need to ask the patient, could you please look to the left side? You are going to check for the JVP. And then warm your hand before touching the patient's tummy. Do you have any pain in your tummy? Don't say abdomen. Do you have any pain in your tummy? I'm going to press now, looking for hepatojugular reflux. Okay, nothing, no hepatojugular reflux. Now you are going to start the examination of the precordium. Examination of the precordium, okay, you need to palpate for the apex first. You need to locate the apex. Is it displaced or undisplaced? And the character of the apex. And then you need to check for any thrills. And then you need to check for any features of pulmonary hypertension, like second palpable heart sound and left parasternal heave. And then you need to go and use your stethoscope. You need to check for the mitral, tricuspid, pulmonic, and aortic area. You need to check for two things, the heart sounds and the murmurs. And then you need to ask the patient to lean forward to check for the second aortic area. The second aortic area is located in the left side, third intercostal space. You need to instruct the patient, take a deep breath, keep it out, and hold. And this is the best place to hear the diastolic murmur resulting from aortic regurgitation. And then you need to put your stethoscope in the carotid area, looking for any radiation of the aortic stenosis murmur. And then you need to go and check the back, looking for bibasal crackles, and to press, looking for any sacral edema. And then you need to ask the patient to lie down, go and check the lower limb edema, thank the patient, cover the patient, wash your hand, and present your findings. These are the steps of the cardiovascular examination, Dr. Ria. Okay? And then you need to be so confident. You need to stay upright hands back, eye-to-eye contact to the examiners. And you need to be very honest. When you don't know or you couldn't find a sign, never ever invent a sign. Say, I couldn't appreciate, or I don't know. So the case presentation or the findings in this patient, the pulse is 84 beats per minute, low volume, slow rising, regular, and synchronous. There is a palpable thrill over the aortic area. The apex is in the 5th mid-clavicular line, 5th intercostal space, mid-clavicular line, 5th intercostal space, heaving in nature. The second heart sound is faint, while the first heart sound is present. You did not ask for the heart sounds, Dr. Ria. They are very important. And then there is a systolic murmur all over the precordium, louder in the aortic area, louder during expiration, radiating to the carotids. There is no any bibasal crepitations. There is no lower limb edema. There is no peripheral stigmata of infective endocarditis. Now, I even forgot, before you check for the pulse, you need to look for the fingers, looking for any clubbing or any features of stigmata of infective endocarditis, like a splinter hemorrhage. So once you have done, as I have told you, you need to be confident and present your case in this manner. This is a 61-year-old gentleman, Mr. Stewart, who presented with shortness of breath. On examination, he was lying in a 45 degrees. Comfortable, not in distress. Positive findings are always start with the positive findings. Do not start with the negative findings. If you start your presentation with the negative findings, the examiners will get irritated and make sure this is going to give a very bad impression. Start always with the positive findings. Positive findings are heart rate is around 85 beats per minute, regular, the pulse is regular, it is low in volume, it is slow rising in character, it is synchronous. Then apex beat is in the 5th intercostal space, mid-clavicular line, heaving in nature. The first heart sound is present. However, the second heart sound is soft or faint or absent. There is a systolic murmur throughout the precordium, louder in the aortic area during expiration with radiation to the carotids. Important negatives, you are still presenting. Important negatives, there is no stigmata of infective endocarditis, there are no signs of pulmonary hypertension, and there are no signs of heart failure. Up to this point, you don't need to stop. You need to give more impressive comments by saying, to complete my examination, I would like to obtain full sets of observations, including blood pressure. I would like to examine the abdomen, looking for hepato or splenomegaly. I would like to check for radiofemoral delay. And finally, I would like to obtain a bedside ECG. In conclusion, I believe that Mr. Stewart has got an aortic stenosis. Full stop. Your presentation is done. So you need to start your presentation with the positive findings, and then the important negatives, and then issues that you need to complete your examination, followed by your conclusion. Is that clear?
Yes, sir.
Okay, very good. Very good. Do you have any questions? You've mentioned something, you've mentioned a fatal mistake, Dr. Ria, when I ask you about the management, the treatment of aortic stenosis. Make sure that patients with aortic stenosis not to receive ACE inhibitors. Patients with severe aortic stenosis, okay, they don't need to receive ACE inhibitors. Why is this? Because patients with severe aortic stenosis are relatively afterload fixed and preload dependent. They are afterload fixed and preload dependent, meaning that the cardiac output does not increase with afterload. So calcium channel blockers are contraindicated and ACE inhibitors are contraindicated. Is that clear, Dr. Ria?
Yes, sir.
Do you have any questions, guys? Any questions?
You mentioned about the severity of aortic stenosis. What is it on the clinical signs that we can possibly pick up from the clinical examination?
Inside this patient, there are several features of severe aortic stenosis. Number one, the palpable systolic thrill. Palpable systolic thrill is a feature of severe aortic stenosis. Heaving apex beat, slow rising pulse, low volume pulse, and soft second heart sound. You can see all of these features are present in this patient. And all of these features are features of severe aortic stenosis. Apart from that, there are other features. Narrow pulse pressure, fourth heart sound. And if the patient has got any features of pulmonary hypertension or heart failure. Okay.
I think it's quite common for aortic stenosis, even in mild cases, to actually have narrow pulse pressure. We have to get the patient's blood pressure to know, but the low volume pulse is quite frequently encountered even in mild aortic stenosis, I think. Or am I wrong?
It's not necessary, by the way, because it's not necessary to find the whole features in one patient. Okay.
Okay.
Yeah. Now, another most important question, the causes of systolic murmur. The causes of systolic murmurs, okay, they are a lot. Aortic stenosis, aortic sclerosis, pulmonic stenosis, hypertrophic obstructive cardiomyopathy, mitral valve prolapse, mitral regurgitation, tricuspid regurgitation, ventricular septal defect, and coarctation of aorta. All of these entities will give you systolic murmurs. Systolic murmurs with different characters. Some of them will give you ejection systolic. Some of you might give you pansystolic murmurs, okay? Some of you might even precede it with some clicks, like, for example, a mitral valve prolapse, etc., etc. Okay? Another most important question, Dr. Ria. Once you start addressing the treatment, do not and ever forget the non-pharmacological part. Treatment is divided into two categories, non-pharmacological and pharmacological. Always start with the non-pharmacological. It's about counseling the patient about aortic stenosis, counseling the patient about healthy lifestyle, and controlling the underlying diseases if present, like diabetes and hypertension, for example, with the regular follow-up in the cardiology clinic. You can see how many points mentioned here under the umbrella of non-pharmacological part. Is that clear, Dr. Ria?
Yes, sir.
Yes, and concerning the pharmacological, as you have mentioned several medications. You just need to keep it simple. Medications to control if the patient is in failure, for example, and the cornerstone or the mainstay is going to be for surgical part, either through valve replacement or TAVI, transfemoral aortic valve implantation. I hope that's clear, Dr. Ria.
Yes, sir.
Okay, so I need you to revise the cardiovascular system steps of examination. And don't forget, this is not a talkative station. You just need to instruct the patient the relevant things. Raise your arm. Do you have any pain in your shoulder? Do you have any pain in your tummy? You are not allowed to take any kind of information. This is not a history station. This is not a communication station. This is not a long clinical consultation station. You are just giving the patient some instructions and asking some relevant, important issues. Okay?
Yes, sir.
Any questions? Okay. If you don't have any questions now, as I have promised you, I will explain the valvular murmurs for you, valvular heart murmurs for you. Just give me a second, please.